The quality of healthcare really depends on the people delivering it. And that's why it's so important for organisations to invest in their medical staff, helping them grow professionally, keeping standards high, and stepping in when things go wrong. But what happens when hospitals or practices bring in locum doctors? Locum doctors are part of the team for a short time, but not fully integrated into an organisation. You'll find them working in both hospitals and GP practices. They're a vital part of making sure that the NHS can keep up with demand. Locums help to cover for staff who are off sick, away on leave, or when there are unfulfilled roles. Some do it as a side gig alongside their permanent job, while others choose to work only as a locum. Hello. Welcome back to Voices for Safety, the podcast from the NIHR Greater Manchester Patient Safety Research Collaboration, where we discuss all things patient safety. A study by Jane Ferguson and colleagues have pointed out that working as a locum doctor can be tough and it can be isolating. That lack of connection with your team in some cases can increase the risk of safe practice. So who better to welcome to this discussion than the researchers leading the way in patient safety and locum working?
So I'm Jane Ferguson. I'm Assistant Professor in the Health Services Management Centre at the University of Birmingham, and I'm interested in the healthcare workforce and quality and safety.
Hi, I'm Kieran Walshe. I'm a Professor of Health Policy and Management at the University of Manchester, and for a long time my research has revolved around quality and safety in healthcare, governance, failures in care, and quite a bit of work around the regulation of healthcare organisations and of healthcare professionals like doctors.
Amazing, thank you very much. To start the discussion, we're talking about locum doctors today. Can you tell us and tell our listeners about what a locum is? Who is a locum and why they possibly move into locum work?
Yeah, so a locum can be any doctor from foundation year 2. So as long as they're a fully qualified doctor and they've qualified, done their F1, so foundation year 1, anyone from then onwards can work as a locum. And so the kind of reasons why doctors work as locums. So if we think about the early years, you've just qualified. Quite a lot of the time, people are coming out of university with massive debt, and so locum can be a way of earning a bit more money than they might have ordinarily, paying off some of that massive student loan that people have got. But also we've noticed that, we know that doctors are less likely to go into those traditional career paths, and also there's difficulties getting into those roles as well. So locum can be a way of testing things out, to try a bit of variety, see what, kind of suck it and see if you like to work in that kind of organisation or you like to work in that role, get a bit more experience under the belt. And for people who are a bit further into their careers, it can be, to do with things like you've had a young family and it's just a more accessible way of working, or you're experiencing burnout. So again, it's a way of avoiding burnout. So you can earn you can probably earn what people told us when we interviewed them, the same as a full-time job in maybe 2 or 3 days. And then further along, towards retirement, it's a way of people kind of keeping their hands in. When sometimes people will retire and they'll come back as a locum. So, it's options for people all through the career path.
And a lot of doctors actually don't just work as a locum. So they may be doing a substantive job in an NHS organisation or a GP practice, perhaps part-time, perhaps full-time, but also doing some locum shifts at the weekend or in their free days. So they'll be doing a bit of both. And it's also worth remembering that locum work is not assured. So in fact, in general practice in the last couple of years, we've seen the demand for locum GPs really drop. And a lot of people who were working as locums have struggled to find work.
That was going to be my next question, actually, is how does that look? Because I assume locum work looks very different from primary care, so GP practices, compared to hospitals and secondary care services.
In hospitals, in NHS trusts, you'll have agency locums who come from a locum agency. But you'll also have quite a lot of what are called bank doctors, and they'll be doctors who work within the organisation but are doing essentially some overtime, some extra work and doing some locuming, and they're on the bank. In general practice, you tend to have far fewer agency locums, and GP locums are often people who are known to the practice. So they might be people who've worked there before, sometimes someone who's a regular locum, sometimes someone who's retired, as Jane was saying earlier, and has come back to work for a part of their time to keep their hand in, but rather less use of, someone ordered from an agency who you don't never met before when they turn up at the door.
There's something to be said there as well about people knowing the system in terms of where to avoid and where not to avoid. And so being well networked was something that we found in our research was important for finding these practices that were easier to work for, safer to work for, but this also had implications for people who weren't well networked. So they might be overseas trained or, international medical graduates who didn't know the systems in the same way, which put them at risk. That was a bit vulnerable for them, they might find themselves in these places because they didn't know the system, they didn't understand the local region in terms of where to avoid and where not to avoid.
That brings us nicely into the topic of this podcast, which is patient safety. I wondered if we could talk about a little bit about the quality of care that locums may provide. Do we have any real insight into the quality of care that locums can give?
On the whole, the research says that if you're being seen by a locum, you're probably going to get about the same kind of quality of care as you'd get from a permanent doctor. Where locums practice differently, it's mostly to do with the way the organisation has used or deployed them. Whether or not they know all the systems and processes, whether or not they have full access to arrangements for ordering tests, for issuing prescriptions, for putting things on the electronic record system, all those kind of, trivial but really important bits of administration. The fact that locums are subject to a bit more by way of complaints and referrals to the GMC is probably a lot to do with how problems with the doctor are dealt with. Because if there are concerns about someone's performance and they're employed in the organisation, that's the way they get dealt with until it becomes really necessary to involve outside agencies. But if it's a locum who is here today and gone tomorrow, there can perhaps be far fewer informal ways of resolving concerns, and it may then end up in a more informal process like a complaint or a GMC referral. So it's really, the research fundamentally says, don't worry too much if you're seen by a locum. Patients actually value some aspects of being seen by a locum. For example, the fresh pair of eyes they bring to their care. But organisations need to up their game in the way they look after and use locums in clinical practice.
That's interesting, isn't it? That patients potentially have a positive perception of locums. Do you think that's a reflection of how they generally feel with their treatment in the health service? Has that changed over time? Do you know?
I think patients generally don't know that they're being treated by a locum. Unless you've got a long-term condition and you're really familiar with your general practice, then you probably don't know that your doctor's a locum. And if you're in hospital, then you've got even less chance of knowing, because that might be a one-off thing unless you're there on a long-term stay. And so when we ask people that question around, should patients know or should you share that information, because there was some negativity with being a locum and carry some baggage with it, just that term. And it was almost like, well, we don't tell people because we don't want them to kind of second guess or feel as though they're getting, less good treatment because they were a locum. So patients didn't always know, and kind of that it depends on what they were being seen for. So if it was kind of a one-off thing, then it was access is king. You just want to be seen. But the people who had a long-term condition, they felt bit of an eye roll of having to start again, tell the story again of why you're here, and just that person not having your history or not knowing what your previous medications were, or having to go through all that again. So I think it depends, and that's a fresh set of eyes and some really good experiences from having that second set of eyes on things where people would talk about, well, the doctor knows me really well, they've seen me all the time, they're just like, oh, here's this patient again, and that they could be seen as a new person by this locum who then might offer some different ways of treating them, which then went on to be life-changing for some of our participants who found it a really valuable experience.
In the literature, there's that idea that when people have multiple conditions and quite complex patients, that can potentially present risks for patient safety when people are treated by locums. So your research would suggest that actually maybe that's not
It
right.
sort of gets to the nub of what you think continuity of care is, because
Yeah.
we all tend to think rather lazily, it means seeing the same doctor every time.
Yeah.
But actually, in hospital, you often don't see the same doctor any time. In your GP practice, that might be more common. But lots of patients told us they didn't generally see the same doctor anytime. So continuity of care then becomes, if you like, information on continuity, knowing that the doctor who's seen you has all the information that the other people who've seen you in the past will have. And I think that's, in that situation, a locum can be just as effective as a permanent doctor. And we do think there was some evidence from locums that they practice quite defensively because they know they're not going to be there next time the patient comes in. So they can't rely on keeping things in their memory or saying something informally. So perhaps they make a bit more effort to document things and to follow things up and to safety net things in the right way. So certainly, speaking personally, I would have absolutely no problem going to see a locum. And in fact, I was talking to my mum last week, and she had just been to see the locum, and she and my brother had a very high opinion of the woman who saw them because she'd been so thorough.
That is really nice to know. Does that is that more challenging when we talk about information and sharing that information, continuity of care? Would there be challenges, do you think, for locums around, I'm thinking in hospital settings, not necessarily being present at handover the next day, not necessarily being able to have that continuity of information? Do you think that's handled by the defensive practice, or do you think that's a challenge that is ever present for locums?
I think that we had examples where that was handled through defensive practice, through locums being afraid to make decisions because they were, scared of the consequences. Because if you're excluded in an organisation, or you're kind of seen as here today, gone tomorrow, then you're not involved in things like the multidisciplinary team meeting. You might not be there for handover. You might not be there for those important things that gives you the whole picture of what's going on. So locums did talk, and the people who work with locums both spoke about practicing defensively to avoid those situations, being afraid to get in there and make a decision that was necessary, which kind of perpetuated that negative view of locums. So, but I think that can kind of was remedied by people being there for a longer period or practicing in fewer organisations. So, people would say to improve safety for themselves and risk for themselves as well as other people, they would just work across 2 organisations and just go to those places on repeat, where they can become more familiar with the staff and become better integrated. I think the highest risk is probably with the very short-term locum in multiple organisations where you were always new. Like, one thing I'd say about this is we all know what it's like to be new in a job where you don't know where things are, you don't know anybody, you don't know who to ask for things. And so it's that, perpetual newness is where the risk lies.
The other side of the coin on that was that locums certainly felt, and we had quite good examples reported to us, that because they weren't in the room, because they'd left and moved on somewhere else, it's quite easy for them to get blamed for anything that happened to be hanging around. And they were sometimes, the place where blame was positioned quite unfairly. And they wouldn't be in the room, and they might find out later on quite accidentally that there'd been a problem, and they had never had a voice in saying why they thought something had gone wrong and so on. So that issue of kind of blame is one that plays out in an interesting way. For locums who are no longer in the organisation, if there's a complaint, there's no way for them to be asked about the complaint and give their views and so on and so forth. At the same time, we did hear people talking about some locums who, when there was a problem, they were moved on or they moved on. So there's 2 sides to that, which you might come to.
Also got implications for the learning, so if you're not there to hear about a mistake that you've made and nobody contacts you to let you know about it, or you're not involved in the complaint, then how are you supposed to learn from that mistake? So I think with that perception of locums being not quite as good, I think that kind of inability to learn and practice and continue professional development based on the things that you're learning about your practice, that is an issue.
NHS employers and NHS Improvement, they all have that guidance, don't they, on locum working. So what can be done, do you think, that can improve that sort of clinical governance and that access to personal development and development for locum staff?
reading the guidance. I think when we looked at that guidance, obviously we looked at it really closely as part of this project, and we worked with NHS England, and we thought the guidance was really comprehensive, and there was nothing that we by the end of the project that we thought maybe we could add to this, or maybe we could change it. It was comprehensive. But what we did find when we surveyed organisations was that people weren't really aware of that guidance, or if they were kind of I doubt that many people had read it. So I think engaging with it, reading it, and implementing some of the guidance in there would be a first step.
I think I'd just add to what Jane said a couple of things. One is some bits of the guidance are very clunky. So, for example, what are you meant to do if you have a locum doctor working for your organisation about whom you have a concern? Well, there's some guidance about what you're meant to do, and it involves reporting it to the locum agency responsible officer and so on. In practice, it's really hard to make it work. And the easiest thing to do is just to get rid of that locum and end their placement, or when their placement comes for naught, and then simply not renew it. So you've got to have guidance that ordinary people can follow and follow sensibly. But also, second point, there isn't a closing of the loop on the guidance, and guidance is only as good as the systems for assuring that somebody's doing what they ought to do. So organisations like the Care Quality Commission, who regulate the health and care providers, probably are the best placed organisations to have as part of their oversight, and they do have oversight of staffing arrangements, staffing levels and things like that, as part of their oversight, to say we might, when we come, check that you're following the guidance on looking after locums. The big hole in that is that locum agencies are not regulated, not by the Care Quality Commission, or indeed by anybody else. If I wanted to set up a locum agency tomorrow, I could do it. And that we felt was a real gap in the current arrangements, because locum agencies, somebody should be checking that they are doing what they should be doing to look after the quality of locums they provide.
When it comes to locums, what is it like for them in terms of supervision on the ground and clinical supervision? So I noticed from your work that, for example, that they may not have regular appraisals, bringing into the idea that the evidence that they need to collect, that development that they need to collect, and that proof for their revalidation shows their fitness to practice. Every 5 years, is it revalidation for a doctor? So do you have any insight into how they feel about any clinical management that they have?
I mean, there's an attitude to locums that tends to say, right, once you get here, get your coat off and get working on clinical practice. And so locums don't get the same opportunities to engage in CPD, or to have training, or to be involved in things like mortality and morbidity meetings and so on that permanent doctors do. And they're also expected to look after themselves, particularly for those processes you referred to, appraisal and revalidation. Now, locum agencies can run the appraisal system, but actually for them to appraise locum doctors effectively is quite difficult, because they're not working with them clinically. They're not seeing them in clinical practice. They're completely reliant on the information the locum provides and that their placements may provide, and they struggle to get feedback from placements. So it's a very imperfect system in that regard. And that does mean that locums then may find it hard to revalidate, which is getting somebody who's a designated responsible officer to sign off on their practice at the end of 5 years. Those arrangements definitely could be improved. And if I had one sort of summary recommendation from the research, it would be that we get healthcare organisations who use locums to treat them much more like other doctors who work in their organisation, and to give the same sort of access to induction, support, engagement in meetings and things like that, and not just treat them as a pair of hands.
I'm assuming that there is a difference there between those sort of internal locums, those bank doctors, and those who are external originally to the organisation. Did you have any insight into that from your work, whether there was a difference there or perception of difference between those two working groups?
Yeah, I think if you could boil this whole project down to one word, it'd be familiarity, and so if you're based in an organisation and you've got your responsible officer there, and you're involved in things, then it's very different from you just doing a shift, or several weeks of shifts there. So it's really different from that sense.
And talking of culture, it makes me think of team dynamics. Are there any challenges there for locums around that sort of familiarity with the teams that they're working with? Not only the systems that we said, not only the policies and the procedures of the local systems, but also with the team and the team dynamics.
Yeah, and I think the obvious difference there is the pay, isn't it? And that causes issues with team dynamics in terms of resentment. So and also that not taking responsibility for the kind of collective endeavor, if you like, in terms of the admin that needs to be done and the leadership and maybe the training of other staff. So the locum, a lot of people said that the locum because they've got control over kind of when they work, how they work, and what they do, but those jobs all still need to be done. And so there was a sense of resentment sometimes from the permanent staff because that work's still left there to happen. Plus, the locums getting this perception of that they're getting paid significantly more. So that caused a bit of friction in the team sometimes. And I think while, I appreciate what Kieran said and I back what Kieran said in terms of organisations need to treat locums much more like other members of staff and integrate them better, there is something there that prevents people from doing that because they're like, well, why should I? Why should I treat you just the same as everybody else? You're not having to do all of these other things. So, it's kind of a little bit seen by the permanent staff as having your cake and eating it, and causes that, kind of rift in the team where the locum might be excluded. We had people who said they didn't feel welcome in the doctor's mess, for example. They didn't feel like they could just go into that space. So, yeah, that kind of exclusion and marginalisation of locums that we've heard quite a lot in this study, but our previous study that we did about revalidation is a really strong theme, and all of the locums that we've interviewed have talked about this, feeling of othering and of professional isolation. And I think as much as you kind of want to say, it should be inclusive, there are some issues there that people find quite hard to swallow in terms of the pay, in terms of not being responsible for all of the work.
You sort of get relabeled when you work as a locum because you might have been, quite a senior consultant radiologist, and suddenly you're just a locum. Your locum identity is what people attach to you. But I think there's good reason for saying organisations ought to push staff back on that, because it's not the locum's fault they're working as a locum. It's the organisation that's hired them. And it's a bit unfair to shoot the messenger and blame the locum for the fact that they're there as a locum. They're filling a shift that would otherwise have been vacant. So, that's what would have been the reality for the other staff there. But it's understandable that people feel some resentment, and it's kind of fed by that narrative about, they're all just milking it for the money. They're all earning thousands of pounds a day, which ain't true.
This is the really big, complex, hard question. But what can organisations do to improve that dynamic between their permanent staff and their locum workers, so the locum workers sort of feel a little less discriminated against, more integrated?
They need to bring them in, that inclusivity. And so I think if I was going to recommend to a locum what they should do, I would choose to work in fewer organisations and work there for longer periods, so people get to know you and you're not a kind of this nameless person. I think when people get a sense of, they're only going to be here for a weekend, people just naturally don't make the effort to get to know that person. But I think if you knew you're going to be coming back on a regular basis and that familiarity, I think that will be a way forward. So what the processes are, because it's like with anything, if a job's new, it takes you a while. It takes you maybe 3 months before you feel as though you kind of get to grips with how to use the systems and what the keypad code is to get down into that ward. So it's all of those things that I think if I could recommend to locums to what to do, but also people to work with locums, is just get to know one another and recognise it's a collective endeavour. It's about patient safety ultimately, isn't it? And so working against that and doing things to kind of exclude a group of people who are really important for patient safety and keep them out of the loop and not give them information that they really need is nonsensical at the end of the day. But yeah, I think that would be my recommendation. Bring people in. Make it more inclusive.
I'd just add, organisations should make less use of locums. And if you're using locums because your HR department takes 12 weeks to process recruiting a replacement for somebody who's left, or for those sorts of reasons, you can tighten up on your arrangements. Use bank rather than agency staff, because then they're not really locums in the sense of people unfamiliar to the organisation. Where you do use locums, use them for longer term. And the key thing to try and eliminate is the use of short-term unfamiliar locums, people who kind of get hired in from an agency for a weekend because there's nobody to cover A&E over this weekend. That's probably the area of highest risk, and where, both for the locum's sake and for patients, it's better if we could avoid that.
There's something, before we move on, there's something to be said around the balance of the number of locums in the organisation as well. And one of the things that's really important is that, locums have been described as the oil in the wheels of, really important to fill in necessary gaps when people are off sick, or, it's hard to recruit to a post. People say the NHS would collapse tomorrow without them, and that's probably true, but they shouldn't be the wheels. It should be the oil in the wheels. It shouldn't be that you've got that many locums in a service that they are the service. Because those jobs, like we said earlier, still need to be done. There still needs to be somebody who takes control, ownership of leadership, who thinks about quality improvement and all of those really important things that locum work generally doesn't look at. So I think oil in the wheels, but not the service itself.
And something that came to my mind when you were talking just is there something where it's infinitely more challenging for locums for who English is not their first language, or come from another country to come and work as a locum? Is that more challenging then for those people on top of the bank and sort of internal locum versus the one who's not known to the practice or to the hospital? And then on top of that, we have this.
It does layer with other identities in terms of, we talk about locums quite often being marginalised and being excluded from things. And then if you're coming from another country and you don't know the NHS systems, it's got to be really hard to get your head around, first of all. But then you're being excluded and not treated the same as everybody else. So it layers that kind of locum identity on top of other identities.
I think there's a big difference between people who are working as a locum because they choose to do so for a whole host of reasons that we discussed, to do with work-life balance, lifestyle, income, other responsibilities, and so on, and people who are working as a locum because they don't have a choice, because that's the job that they can get. And certainly some people coming into the UK from outside, their first jobs may well be working as a resident medical officer in a private hospital or as a locum. And we know from all the research the GMC has led on this, that those doctors are particularly in need of support and help, and perhaps, least suited really to be working independently, and really need the scaffolding that you get from working in an organisation with other people who can support you.
So, talking of support, what support would really be needed for locums, do you think, from their point of view?
Induction, so having a really thorough induction. And so one of the things that we could have done in this project is we need a really comprehensive induction pack, but that's quite often already been done. But the issue being there is locums quite often aren't paid to do that. And so therefore it's kind of, they've got to meet the organisation halfway and take the time to do that in their own time, which people are reluctant to do. So that kind of sense of inclusion and that, proper programme of induction doesn't always happen because it's not paid for. So do organisations pay for locums to do that? And is that going to be acceptable to people, that we're going to pay you to do that piece of work? We're going to pay you to do the training that we need you to do. We're going to pay you to come to multidisciplinary team meetings, because quite often locums are employed to serve a clinical needs, so we need kind of hands on deck to be able to do this job. And you're not paid for all of those other peripheral things, but are also really important for patient safety. So I think it's going to cost, locums are going to have to be paid properly for induction, paid to go to team meetings that they might not otherwise have been at because they're on the ward doing the job while everyone else is in the meeting. So it'll cost more money ultimately, which is a bit of a kind of an issue, given that one of the things we hear most about locums is the cost of it. So to make it safer and to better integrate them will be more expensive.
If there's one point, Kieran, for you. So I know Jane has given her sort of one point of what's most important, I think, to think about patient safety with locum workers. But for you, what would be the most important take-home point?
I think it's doing things that get organisations involved in this to, as I said earlier, up their game. That's partly about following the rules that already exist and the guidance. It's also about creating a framework for overseeing them that doesn't exist at the moment. So regulating locum agencies and making sure that organisations who use locums are doing the things that they need to do to ensure that patients are safe. It's not rocket science.
Yeah, thank you. Thank you for that. I think that's a really nice that's a really nice point to end on, isn't it? It's not rocket science. For you, both of you, what is your driver for working in patient safety on a personal note? And what is it about safety and quality that is really enticing to you to work in these fields?
I think that's an easy one, isn't it? I think you only need to spend time reading patient stories or, in the press or whatever it might be to light enough of a fire under your backside to do what you do. And I think Kieran and I are just moving on to a project about unprofessional behaviour among staff and what that means. So I think knowing the effects of unprofessional behaviour on people and how harmful it can be to their mental and physical well-being, I think that's kind of what gets me up in the morning.
This is where I'm going to sound ancient, but I've worked in the NHS for getting on for 40 years. And I worked initially as an NHS manager. And I think it's only when you look back, you realise how far we have come. So when I was an NHS manager, clinical practice was a secret garden. What doctors did was no one else's concern but that of other doctors. And we have travelled a really long way in a kind of opening up, if you like, the secret garden and getting in much greater transparency and accountability, and also greater support and engagement and lots of good things for people who work as a doctor. I've never wanted to be a doctor. I don't know how I'd cope with the responsibility of making some of the decisions that doctors make, and I have a huge respect for that. But I think we are now doing a much, much better job of training, developing and supporting doctors to be safe in practice. And that's really satisfying.
Amazing. Jane and Kieran, thank you so much for taking the time out of your busy day to talk to us about the challenges of locum working for locum doctors and the organisations and healthcare teams that they're working with. And listeners, thank you for taking the time out of your busy day to listen to our podcast today. If you want to find the papers and the show notes, you can go to our website, as always, psrc-gm.nihr.ac.uk/podcast. You've been listening to Voices for Safety, the podcast that explores the forefront of patient safety research, brought to you by the NIHR Greater Manchester Patient Safety Research Collaboration. If you enjoyed today's discussion and want to stay updated on the latest in patient safety, be sure to follow us for upcoming episodes. You can also find us on X, Blue Sky, LinkedIn, and on our website, www.psrc-gm.nihr.ac.uk. Join us as we continue to uncover insights, innovations that make healthcare safer for everyone. Thank you all for listening, and we'll catch you in the next episode.